extensive scars on the skin and soft tissues observed on the anterior medial aspect of tibia. A bone defect is exposed layer after layer. Bone ends are separated from scarred tissues. Due to evident sclerosis, the bone is pre-drilled along a resection line in the proximal fragment, to be followed by economic resection and hemostasis. Shown is a macroscopic view of the bone excised. After the wound has been cleaned, interrupted stitches are applied. Tibia is osteotomized with a chisel in the upper third out of a 2 cm skin incision for bone transport and limb lengthening. The rods get loose to check mobility of bone fragments at the osteotomy level by rotating the rings, and then tightened to prevent displacement. Additional wires are placed to improve stability of osteosynthesis and prevent secondary displacement during distraction. Radiographs show osteotomy and realignment achieved. A 2 cm bone defect formed with bone ends being congruent. Skin stitches are used and aseptic dressing is applied. Patient's radiographs during treatment. 10-day distraction, the limb axis is well realigned. Diastasis of 1 cm formed in the upper third of tibia at the level of osteotomy. Bone transport commenced on postoperative day 5 to 7 at a rate of 1 mm per day over 3 to 4 fractions depending on the quality of distractional regenerate bone. Foot deformity correction was produced during 10 days using hinges in combination with bone transport further on. Radiographs shows a satisfactory docking site in the middle third of tibia with good alignment and a regenerate bone of moderate optical density formed in the upper third. The patient could walk using crutches and shoe lifts and do physical therapy exercises at the period of rehabilitation. Distraction continued to compensate discrepancy. Radiographs showing a nexus of the limb corrected with satisfactory bone fragment contact. Foot deformity eliminated and diastasis of 5 cm filled with regenerate bone of moderate optical density in the proximal tibia. On discharge, the patient could walk with crutches, maintaining partial weight bearing on the left lower limb. Limb length discrepancy eliminated and the foot deformity corrected.
Colleagues, maybe anybody questions about film?
When you are doing a transportation, like this what you have shown, why you want to do a osteotomy of fibula? When you are doing a transportation, you are only tibia you are bringing down. Fibula has nothing to do. Why to do osteotomy?
Значит, я понял. Это самое. Делается остеотомия малоберцовой кости в двух ситуациях. Когда она мешает компрессии и когда требуется удлинение.
So only there are two reasons to make fibular osteotomy. When you are making compression. So there are only two reasons to make fibular osteotomy: to make compression or to make distraction. Anyway, it will prevent distraction or compression if we will not cut it. So the regenerate is about 4 centimeters. Callus is about 4 centimeters. So the reason for this case to make osteotomy of fibula is that we want elongation more for 4 centimeters in the tibia, for 4 centimeters.
I personally feel when you do the fibula osteotomy, it becomes very easy to correct the deformities, because fibula is a fixed like pillar. Until and unless we do not cut the fibula, it becomes very difficult to correct the realignment. By that way, the fibula helps the osteotomy.
It's like comment, yeah? So, yes, we agree. То есть намного проще просто манипулировать, когда остеотомия сделана, может быть. So we really don't use grafts. We don't need them. Sorry. So in addition, for the previous thesis, it's very important to make osteotomy of fibula anyway, because we don't know about the process in whole, about the future. So it's better to manipulate, it's better to have freedom and make osteotomy of fibula anyway. And it's oblique osteotomy because it's very easy then to manipulate. So anyway, we use this method, use this osteotomy in more cases which are complex cases. So if you want to make compression, you need oblique osteotomy to make it free.
So what?
Ну, отрезают кусок фибулы.
Величина резекции и характер определяется, во-первых, в основном интраоперационно и зависит, значит, от того, конгруентна клонка или нет. Если не конгруентна, всегда резекция в том или ином объеме.
The size of fibular resection, it's usually the choice which is made during surgery procedure. So it depends on the size of non-union, really.
Excuse me.
So, yes, we can make mistakes using X-ray. It's better to understand what will be the size of osteotomy resection of fibula only during procedure. So the last decision must be made during the procedure, not only using X-ray.
So one question. Excuse me. Yeah.
And we had another question. Sorry, can you repeat, please? We are sorry.
Mm-hmm.
Yeah. No, we don't do this, really. So at first it was a gap. Yeah, and then yes, and then we transport it and make compression. Yeah. Yeah. No grafting. No grafting. No, only one surgery, open surgery in the beginning. You don't need it. All other procedures are closed. You don't need to make another surgery to get some grafts into the non-union site. So we use grafts only in congenital pseudoarthrosis, only in congenital non-unions, not in post-traumatic non-unions. We'll show your congenital non-unions later. We have a lecture about this. Okay?
So excellent presentation. I wanted to ask question, why not in this case you have selected acute shortening? Why bone transport? It was very small.
Почему
gap.
вообще мы? So we need much elongation in this case. So it was the cause why we used bone transport.
Да, мы полностью не удлиняем. Бывают случаи клинические, но полностью не удлиняем, когда есть проблемы с голеностопным суставом.
In some cases we don't use full elongation because with the problems with the foot.
Есть легкий эквинус, и вы предполагаете, что полностью его компенсировать не можете.
If you see that you have problems with foot, you must not elongate too much.
Чтобы многофункциональное длинение не было, иногда оставляет небольшое укорочение.
Yes, sometimes we don't elongate for full size because function is more important.
This is not elongation. I am talking about shortening.
Acute docking and then lengthening.
You mean acute docking and then elongation?
Yeah.
Почему не использовали сразу компрессию в зоне неоартроза, да? Ну, в смысле, где мы вырезали?
Они не конкурентны. Дело в том, что продолжали замещать дефект.
Нет, почему сначала не сделали компрессию, а потом не начали наращивать сверху?
А так и произошло. Сначала ушли на контакт.
Сначала ушли на контакт? So at first we go to the acute compression, and then we began to elongate. Yeah, absolutely.
Yeah, because this will solve the problem of equinus also. The foot correction will be instantly can be achieved.
Absolutely.
And this is advantage for union also. The union will start from day one. So that's all advantages for docking.
At first it was compression and then elongation. Yeah.
Старались максимально выйти на контакт, а потом доудлиняли.
But if we do the acute docking, what about the fibula? Because fibula with overlap, then it becomes difficult to lengthen the fibula. So that is the main problem. So why we should do the overlap?
Почему все-таки с захождением они?
You can go for lengthening then.
Все они разбираются.
Not a problem.
I
We are
have
doing.
one last question. Whenever there is middle third of tibia involved and we do these kind of surgeries, I have never fixed the foot and ankle. I use a foot piece and connect it with straps onto the last string, like a shoes or a sandal. And only if there is some equinus going on, then I take them back and put it on this one. Otherwise, physiotherapy and weight bearing on that limb, without fixing the foot and ankle, in middle thirds of tibia, helps quite a lot. Very rarely I fix ankle and foot.
Equinus before.
He had equinus? Okay.
Yes.
Да, понятно,
Foot
почему
is
он вообще
the
спрашивает.
fixed
по поводу
deformity.
использования стопы.
So we have to correct the same thing. We have applied the apparatus. It's a fixed deformity. So it's necessary.
Necessity, yes. Okay, we are running time short.
Okay.
No?
Okay.
Let them talk. Any question from the audience, please?
Okay. Для детей и взрослых одинаково.
Нет, значит, 1 миллиметр это максимальная величина удлинения.
So 1 millimeter is maximum. Anyway, in some cases we use less.
При лечении пациентов с сложными суставами вы имеете дело с теми пациентами, у которых низкие репаративные возможности.
So in the cases with non-unions, you have very bad quality of bone,
У них очень серьезный предшествующий анамнез.
and they have very bad history with the illness. So we used.
Большинство из них перенесенные стимулы.
Some have or had osteomyelitis in their history.
Поэтому бурной регенерации не приходится ожидать.
So the regeneration is very poor, really.
Мы рекомендуем не превышать дистракцию 1 миллиметр.
So we use distraction not more than 1 millimeter.
Но, как правило, на бедре и голени это дистракция 0,75-1 миллиметр.
But on femur and tibia, it's usually not 1 millimeter, but a little bit less.
Предплечье, плечо 0,5-0,75.
And upper limbs, it's about 0.75. It's not a cosmetic surgery, so here you must be very slow with distraction.
So in children,
In children the same. As usual 1 millimeter, the same.
Я просто рекомендую проводить своевременный мониторинг.
So it's very important to make a good follow-up, to check the situation, make X-rays, because sometimes you can catch good solid callus. So it's very important to control the site of osteotomy. Is osteotomy full or not? Especially in corticotomy, or it is in osteotomy. It's very important to control by X-ray. So metaphysis is the best site for elongation. So you can be more fast in metaphysis. But if you are working on the aphysis, it's a big challenge, and you must control it very, very exactly. So if you make some mistakes in the aphysis, the risk of complications is very high. But anyway, if you are using iliZarov, you will find the safe outcome. And even without grafting, you can solve the problem. So we'll show you later in our lectures about defects, about congenital pseudoarthrosis, all this material. Okay?
Okay.
One more.
Okay, there's the time. Okay, understood. Now,
Вилку сустава, если защита вилки сустава.
You come to the microphone, please.
Yes, we understood the question. Yes, it's. But we understood. It's very important to control fibula and tibula position one to each other. Yeah, you mean this?
Yes.
Yes. To fix them together in the distal part. Yes, it's very important. In proximal side, it's not so important, but in distal part, you must use additional wires to make good contact with fibula and tibia. Yeah. Not screws, it's usually wires with the stoppers.
So you use 4 wires in the first ring, then there is a drop wire in the second ring, and there are 3 wires in the ankle, in the near mortises. I haven't seen the adjustment for procurvatum in the ring. So whether you keep the ring straight or you keep it in a angle manner to correct the procurvatum in lengthening?
Yes, we usually make this a little angle in the ring. It depends on the deformity of tibia. But we usually do this. And we used hinges very often.
And why 4 wires in the first ring?
Почему 4 спицы? It's better to use more wires in bad cases where the process was very long and it was non-union osteomyelitis and osteoporosis. So we use more wires to make more stable construct. So if the part of the bone is too short, it's very important to get more wires in it. So we use the maximum amount of wires and with the maximum distance with each other. Yeah. And use stoppers to make it more solid.
Thank you. Thank you.
Any other question from the audience? From the young stars? So no question. Next, proceed to the next speaker. Now, Alexander Vadimovich Gubin, he is the young director of the Russian iliZarov Scientific Center. is going to talk on iliZarov philosophy and iliZarov Center now. Alexander Vladimirovich Gubin, please. He told me that he is going to.
Thank you again for inviting us to India, to your beautiful country, in which iliZarov method is very useful, really, because you have a lot of patients, a lot of cases, and for me, and I hope that it will be for you in the future, the most important is that when you have iliZarov method in your hands, you are first of all safe, and second, you are free. Because if you know how to work with iliZarov frames, if you know the principles, the main ideas, you will be free in every other fields of orthopedics and traumatology. It's very important. So I'll say you a little bit about our center in general, about the idea of iliZarov in general, because it's very important. Every man has different periods in his life. Childhood, teenager, oldness, and what is more important, maturity. So now it's really 60 years of iliZarov treatment, iliZarov method in the world. So it was introduced 60 years ago. Of course, it's the age of maturity for any method. And it's very important to find what is good and what is not. What are the right indications? What are the future of method? How can we use it widely? So all these questions are, of course, discussed in our center. It's very important to understand what will be in the future. So really we have a lot of challenges, and I will speak a little about them. And what is very important? What is iliZarov method? It's method, it's kind of ideology, or it's kind of philosophy. And we will speak about people who use iliZarov method, and it's very important too. And we will speak a little bit about concepts, about our days, and about near future. So what is going wrong with iliZarov method in the world and in our country too? We have what we call iliZarov method busters. And of course the first one is comfort demands. People want to go to their job, to home very quickly. It's a big problem because we have frame, and to organize their time with this frame, it's a little bit hard situation. But anyway, we must think about this. Insurance and industry, different companies, they have great pressure trying to sell their constructs, their hardware, and it's not very profitable for them to produce frames. So we have this great pressure of industry and insurance companies. Anyway, it's so in India too, I think so. Another big problem why we are here is educational problem, because it's not so easy to understand how it works, how to do the best work. So it's another educational process than in classic orthopedics. So education is very important. But a very great problem which we had in our center and which we met anyway in the world, it's the question of ideology. So in my thoughts, iliZarov method, it's not ideology. Because some people think that it's impossible to solve all problems with iliZarov method. So, like in this big military coaster, you can go anyway and solve all problems with the strengths of iliZarov method. It's impossible, really. Believe me. Some people say that it's an old ship, that it's ancient, it's not modern, so we have new one, and it's not absolutely true. So it's excellent method. Another big problem is the ideology of apparatus race, because a lot of people, after introduction and during introduction of iliZarov method, they produced their own frames, and they used to say that my frame is best. iliZarov frame is not as good as mine. It's quite popular, and all these people were fighting with each other for the best frame. And I think that it's very, very silly to fight for the frames, because all these things are based on one. They are based on iliZarov philosophy, iliZarov approach in general, because iliZarov made a lot in general concept, not only in frames, not only in details. So iliZarov for me now, it's a very good big ship, comfortable coaster, but it's a great safe boat, and it is great investigation mechanism, investigation tool. So for me, iliZarov, it's philosophy, because it is based on the basic great principles. First of all, it's iliZarov's law, or tension stress law. It's very important. It is based on experimental and theoretical base. And of course, early activity and rehabilitation is very important too. And another very important thing, that bone and soft tissue management can be made very well using iliZarov method. But the main principle is, of course, full time control. Some people say that there are a lot of frames were made before iliZarov, but really the method was introduced by iliZarov. So the difference is like Leonardo da Vinci, who was writing his aircrafts, and brothers Wright, who made them. So it's the same difference really. So now on our monument to iliZarov in our center, you see the main principle, the main law is iliZarov law. So it's most important of things he was made. And as an experimental and theoretical base, iliZarov frames and iliZarov principles, they are very handy tool in research. So you can use widely iliZarov approach, iliZarov techniques in every kinds of experiments when you need to control bone formation. It's very easy. Speaking about early activity and rehabilitation and bone and soft tissue safe management, the same principles are in AO. But iliZarov introduced them very early, in the early 50s. So AO and iliZarov principles are the same, but iliZarov techniques and iliZarov principles were made more early. But full-time control needs indications, and it's very important. What are the main indications? It's period of elongation, bone transplant and complex deformity correction, and it's joint control and unloading, and it's tissue problems and wound management. Theoretically, all other problems can be solved without external fixation. We can use combinations. About iliZarov-minded people, I hope I am. And I hope here are a lot of iliZarov-minded people too. Because who are iliZarov-minded people? People who are rules busters, who are decision makers, who are creative, distrustful, and they want to control all period of treatment. And they are of course good people because they are ready for long relations with their patients. They don't want to do surgery and then get away anyway. So they need contacts, long contacts with their patients. So for me, making iliZarov is like playing chess, because it's not a one-stage process. It's a process for a long period of time. You are making match. You are playing chess. You can improve the situation on your deck. So it's very interesting. So what is way out in this very hard economically world? Of course, all of us, we must based on iliZarov philosophy, not only on frames, but philosophy will help us to improve. We can use amount of combinations, but if you have in base iliZarov, it's quite simple. So we call this technological continuity, because in general in our concept of our center, technological continuity is a very important thing. So we must unite iliZarov-minded people. For this we have ASAMI World, ASAMI Russia, ASAMI International. ASAMI is very important because it can unite people. We have magazines and new one which can unite people too, iliZarov-minded people. And another very important issue that we must integrate. So we are not marginals. It's a part of classic orthopedics now. It's classic now. So integration is very important in all fields of orthopedics and traumatology. So with Dmitry Yurich Borzunov, we wrote this article and published it in our general magazine of ASAMI Russia and International Orthopedics about what we are thinking will be the near future of iliZarov methods. And we wrote about our problems in general in this article. So now it is published and you can find it in International Orthopedics. And we based on 4 very simple principles, very simple areas. So we divided all research in 4 fields, only in 4 simple words. First is barrier. What is barrier? We are going through outside to inside the body. We are fighting with osteomyelitis. All this is barrier of the body against infection. So it's very, very interesting and very, very important field of research. Then control, because the idea of iliZarov is to control the process, to control everything. So another very important thing is control. Then stimulation, because we are speaking a lot about stimulation of bone, and you can use iliZarov and different combinations of iliZarov method and other approaches to make stimulation. It's another big field of investigation and for improving our method. But what is very important? We must think about comfort. The system must be more light and light, more comfortable for patient. In the future we will control all our movements, all our changes in our construct using internet, using automatically movements, automatically distractors. I think it will be so, especially it's quite, it may be quite popular and easy in India because you have the best programists, the best software in the world. So you can be very, very active in this field, to be the first. So in general in our center there are very simple strategy which we can call in 3 words. It's first of all age and technological continuity. Because people in our center can go to us and have treatment from zero months, years of age, till oldness. And it's very important, because it's important to understand what is going on step by step. So age continuity is very important in orthopedics in general, very important in iliZarov philosophy, and absolutely mandatory to analyze in our center. Another very important issue is technological continuity. Be free to change different ways of treatment, to combine them, and you will feel the power. If you will combine, if you understand all ways of treatment, you will be free and safe. And of course, team. It's very important to have multidisciplinary team. So now we try to unite different people, different approaches, different scientists, different practitioners to make a good team. So these 3 main principles in our strategy are very important. So in general, we have now about 20 departments. 16 are orthopedics, one big neurosurgery department, and a special bone infection center with 3 departments. The only one center in Russia is for 135 beds, separate building, especially designed only for bone infection. We have our journal, which is the Journal of Asami Russia, and we publish here our articles in Russian or English. We have training courses and master classes. And welcome to iliZarov Center. We'll be happy to see you soon. Thank you very much. If you have any questions, I am ready to answer you in general about our center and about our strategy.
Question to Alexander Vadimovich, please.
Yeah, one thing I want to introduce you. Professor Govind has been agreed to give 2 fellowships to Indian fellows for 6 months. So please clapping. You know, he is such a dynamic. I told him that it will be 2 weeks to 1 month. He said no. In 2 weeks and 1 month nobody can learn anything. So clapping gives can happen, and they can contact me for the fellowship of 6 months for the Kurgan Center.
And I must say that Indian guys were very active. And I think that new fellows will be active too, because they wrote, if I'm not mistaken, they made 6 studies. Because in our fellowships we have a big idea that it must not be only education, not only practice, but it must be some investigation too. So we are asking about investigation. It's very important for growth, for understanding. So investigation is very important. We have a lot of data, a big archive, but we don't have enough investigators, because for 40 years we collected amount of data. So we will be happy to see young, active researchers with whom we can share all our information, all this data, to make perfect job, to make perfect studies, to publish them in international magazines, and to grow with us. Thank you very much.
Any questions? So thank you very much, Mr. Govind. Now again Dmitry Yurievich is going to talk on osteomyelitis, please. Нет, he's here. This is here, Manish. You have a lecture today? No? No. Tomorrow.
Final presentation or the session?
Of the session, yes. Yeah. Probably he is going to talk here. Bodygotomy and technique. Next session.
Yes. Thank you. Okay. Excuse me. Dear colleagues, a lot of patients with pseudarthrosis and defects of tibia and femur complicated with osteomyelitis has been treated in iliZarov Center. Positive result in 98.1%. In most cases, the process of pseudoarthrosis formation under purulent infection is accompanied by bone loss at the ends of fragments and by anatomical limb shortening of 1 degree or other. As a matter of fact, we deal with an acute bone defect, sounds it is called pseudoarthrosis by us. Defect classification. Defect pseudoarthrosis, defect diastasis. Each classification should reflect the main things of disease and contribute to a physical selection of the optimal tactics and technologies of restorative treatment in every specific clinical case. The main task of the restorative treatment of patients with pseudoarthrosis and defect complicated by stimulators A. Stability elimination, the focus of chronic purulent infection, maximal anatomical and functional restoration as possible. The system of reconstructive and restorative treatment of patients with long bone defects by iliZarov is based on the following principle to rehabilitation approach. Fragment lengthening, healing in the docking sites, tibial fibula synostosis, and gradual tension of interfragmental tissue with the regenerate formation. Classification of osteomyelitis basic technologies according to iliZarov is represented on the slide. The scheme of the monofocal transosseous osteosynthesis. Patient's diagnosis with pseudoarthrosis of femur, intermedially locking nail, osteomyelitis, 5 cm shortening, fistulography, sequestral necroectomy, fragments, adaptation, open adaptation, fixation using iliZarov apparatus. Short-term follow-up, fistula closed, integrity of the bone was restored. The scheme of bifocal transosseous osteosynthesis. Patient's diagnosis with tibial pseudoarthrosis, osteomyelitis. Sequestral necroectomy of tibial fragments, fixation using iliZarov. Defect was substituted with lengthening of the proximal fragment of tibia. Short-term follow-up, no fistula, integrity of the bone was restored. The schemes of the polyfocal transosseous osteosynthesis. Patient's diagnosis with pseudoarthrosis of the femur, intermedially nail, osteomyelitis. 14 cm of shortening, true defect and 20 cm. Fistulography. Senation surgery with fragments, sequestral necroectomy, and fixation of femur and tibia using iliZarov apparatus. Treatment result. The scheme of the femoral tibial synostosis, lengthening of the femoral and tibial fragments, anatomical shortening was partially reduced. The scheme of the tibial reconstruction using fibula. Patient diagnosis with pseudoarthrosis of tibia, osteomyelitis, fistulography. Sequestral necroectomy of tibial fragments and fixation of tibia using iliZarov apparatus. Reconstruction of tibia using fibula. 1.5 years follow-up. No fistula, bone integrity was restored. Fibula is hypertrophied. Conclusion. iliZarov method is highly effective in treatment of patients with pseudoarthrosis and defects of tibia and femur complicated with osteomyelitis. Thank you for your attention.
Thank you very much. Anybody question with Professor Brusonov?
Very nice presentation, sir. One patient I saw corticotomy going oblique in tibia for big gap. So you might have purposefully done to get more regenerate?
Смотри, все-таки надо будет translate. Help me. Малоберцовую стетомировать в каком случае, что ли?
So please.
The question is that one patient had a gap and he has done a corticotomy in oblique fashion in tibia.
Косая стетомия. Почему косая стетомия? Откровенно говоря, мы в последнее время возвращаемся к косым остеотомиям.
Frankly speaking, now we're trying to use oblique osteotomy more and more.
Это в определенной мере наша история.
So it was our history.
Никогда косая остеотомия не дает плохой регенерации.
Oblique osteotomy usually provides good callus. Yeah.
Большая костная рана, большой регенерация.
Because if you have a big wound, bone wound, you will have good callus.
Это практически полная гарантия хорошей
So
регенерации.
it's guarantee for good callus.
Сейчас доктора, которые сомневаются в пациенте, в его репаративных возможностях.
If you are not sure about patient's possibility to fuse,
в отдельных случаях делают косую остеотомию.
It's better to make oblique osteotomy.
Yeah, but it goes from metaphysis to diaphysis, and you had an option of only metaphysis against this oblique metaphyseal diaphyseal, which is better.
Идет до диафиза, да? Спрашиваю.
Да, я понял. Значит, все зависит, иногда определяется наличием даже рубцов.
It depends on scars.
Если вы хотите щадяще отнестись к мягким тканям,
if you want a very good management for soft tissue,
остеотомия делается из нескольких небольших разрезов.
You will make osteotomy from different approaches, little approaches.
Там, где она должна пройти, проводятся спицы, спицами
So
рассверливаются.
in the places where you decided to make osteotomy, at first you make a pinch by wire.
Она получается направленная.
So you can
connect.
Yes, connect them easily.
Принципы те же, которые были на видеоролике.
So the same principles we shown you on our movie, on our brief movie before.
The second question is, when there is a big gap and you are doing bone transport, have you faced any problem of docking, not going into union, and you require some surgery to increase the potential?
Были проблемы, вообще были такие проблемы со сращением при...
Значит, основная проблема, то, что уделяется внимание, это полное выполнение санирующей операции.
So in osteomyelitis, what is more important to make very good first sanation, get away all bad bone.
Если выполнена полная санация,
if you do this,
рана заживает первично.
The wound will be okay.
Соответственно, вы имеете дело с жизнеспособной костью.
So the bone is alive.
И при стыковке проблем со сращением,
and after contact, after liquidation of gap, you will not have any problems with fusion.
У нас лечат остеомиелит достаточно радикально.
So we used radical methods for treatment of osteomyelitis, big resections.
Несмотря на точную фистулографию,
even if there is on an X-ray, it's a little problem.
По данным компьютерной томографии,
we use CT to control the situation.
Поражение, большое поражение.
And we usually see more big problem than on X-ray.
В том числе канальная.
And the intracanal problems with their infection.
Поэтому выполняется обширная секвестральная хирургия.
So we used to make big resections.
Фактически в пределах здоровой кости.
So it's like in oncology, so to healthy tissue.
И сращивать на участках здоровой кости достаточно.
And if you will do this promptly, if you will make this cut, this osteotomy promptly, the bone on the ends will be alive, and it will be no problem with the consolidation with fusion.
What about the skin going into the gap?
покажу позже, не затягивает ли ее в...
Collapse.
Дело все в том, что транспорт, дозированное перемещение принципиально улучшает реологию мягких тканей.
So when you are making transport, when you are making any distraction, the rheology, vascularization of tissue becomes very good.
И в тех ситуациях, где, казалось бы, необходима пластика,
And even in cases where you are thinking about tissue plastic or skin plastic,
доктора от этой пластики
you don't need it.
отказываются, воздерживаются, потому что восстановление кожных покровов и дефектов мягких тканей проходит очень активно.
You don't need it because this stimulates soft tissue very good, and sometimes we don't need any more additional plastic, any additional surgery on the skin.
Закон iliZarov, эффект iliZarov действует не только на костную ткань, но и на мягкие ткани.
So the law of iliZarov, it's not only about bone, it's about